Welcome to the trauma lecture. You will learn throughout this course injuries specific to certain body systems, like a tension pneumothorax that occurs in the lungs, or a traumatic brain injury that occurs to the brain. This lecture gives you an overall picture of trauma, how victims are assessed, and how they are managed once they arrive to the trauma center. I'd like to begin certain lectures with data gathered from the CDC. Here are some sobering facts regarding unintentional deaths in children. As you probably already know, the CDC data lags a few years behind our current data. Pause the presentation and take some time to read the following information. We have known for years that teens are risk takers, and in the day and age of texting while driving and not wearing a seatbelt, the data is not surprising. I recently read where texting while driving has been reported to be 2 to 3 times greater in individuals younger than the age of 25. I won't even go into issues with speed. Children die in motor vehicle crashes due to not being properly restrained. Trauma deaths are preventable. When we think about overall causes of death per year for all age groups, so often cancer and heart disease would top our list of guesses. But this data shows that in 2020, unintentional causes of death due to injury was double that of cancer and heart disease. The overall killer is poisoning due to overdoses. As the older population are living longer, the number who die from falls is also exponentially increasing. The last image I wanted to share with you is a good summary of unintentional trauma deaths overall in the United States. By the way, no room for bragging rights on this statistic, but Delaware leads all states per capita in drug overdose deaths. If you do your research on Healthy People 2030, the U.S. Department of Health and Human Services have set many goals, and there are abundance of them, that address specific health conditions such as addiction, obesity, chronic kidney disease, and dementia. Goals also address health behaviors such as tobacco use, drug and alcohol use, and physical addiction. There is an area on injury prevention, and this table gives you a snapshot of how well we are doing in the United States. Even with all of our best efforts of education and community outreach, our report card is not looking good. When you think about a disease triangle, think about the factors that contribute to illness. A good example is pneumonia. A susceptible host, your patient, has been exposed to bacteria through the air in most instances. The pathogen, which settles into the dark, moist, and warm environment of the respiratory tract. Your patient becomes sick with a bacterial infection. It's often preventable. If the immune system stays intact, people who are sick stay home and not expose themselves to others, and the host has effective cilia to keep secretions out of the alveoli. Trauma is often as preventable. If it is raining, those environmental factors should alert the driver to slow down. If the host is impaired due to drinking or drug use, then they are driving conditions exist that increase the chance for a motor vehicle crash. Instead of a pathogen, cause of the traumatic incident is referred to as mechanism of injury. Therefore, one of the keys to trauma care is to be aware of the mechanism of injury, and based upon it, predict the potential injuries as a result of the incident before you lay a hand on the patient. Trauma care requires all involved to have keen assessment skills, and an accurate scene survey by EMS providers must be relayed back to the trauma team in the emergency department to effectively care for this patient. Types of questions the ED staff will ask EMS providers include the use of restraints or bike helmets, for instance. How many steps were involved in a fall? What did the victim land on? What did the fall victim land on? What did the steering wheel look like in a motor vehicle crash or the windshield? How far was a hit pedestrian thrown? Other factors that need to be considered include the speed of the car at the time of impact, how long the impact was exposed to a cold outside environment. This type of information is crucial to effective trauma care. When EMS arrives at the scene, one thing that will be noted is the presence of a child's car seat in the back. If there is no child in the car seat and the driver is not able to communicate information, it is imperative to find out if the child was with the driver at the time of collision. This may require an extensive search until the information can be obtained. In this picture, it is evident by the shoulder abrasion that this was the driver of a motor vehicle and the seat belt was on at the time of collision. What this abrasion also tells you is that the seat belt was in the wrong position, as it was resting too high on the neck versus the shoulder. Therefore, due to mechanism of injury, the assessment will attempt to rule in or rule out injury to the trachea and esophagus, jugular vein, carotid artery, clavicle, ribs, heart, and lungs. So it's important to know your anatomy. This gentleman was the driver of a vehicle and had his shoulder harness in the appropriate position, but not a lap belt. It was sitting too high on his abdomen. This patient will be ruled out for myocardial and thoracic trauma, as well as liver, pancreatic, stomach, and bowel injuries based upon the force of the impact. Reporting the mechanism of injury gives the trauma team an idea of the type of energy that was transferred from the environment to the patient. They include most commonly a mechanical force or kinetic energy, such as a motor vehicle collision or a baseball bat. Good example of thermal energy is a burn. Chemical injury, which could also be a burn due to some type of inhalation or contact injury. Electrical energy, such as lightning or electrocution, and radiation-related injuries. Death due to trauma can occur at 3 peak times. The first one occurs within minutes of the traumatic accident. This usually has to do with irreversible neurological injury such as decapitation or vascular injury such as aortic transection. The second peak time occurs within what is referred to as the golden hour of trauma, which is the first hour following the initial traumatic incident. Survival rates increase dramatically during this time if the patient arrives at an appropriate trauma center within that hour. Injuries where this pertains include brain bleeds and major thoracic trauma. The third peak occurs days to weeks following the incident due to sepsis or multiple organ failure. For the patient that arrives in the emergency department within the golden hour, care will be focused on 3 things: preventing acidosis by ensuring adequate oxygenation, ventilation and perfusion, preventing hypothermia, which can worsen bleeding, as cold blood does not clot, and cold blood shifts the oxyhemoglobin curve to the left, so cover the patient with warm blankets. The third is coagulopathy, stop the bleeding. As you can see, they are all interrelated, so nurses must remain vigilant in their care. Most mechanical trauma can be classified as blunt versus penetrating trauma. Blunt trauma basically means there's no communication between damaged internal tissues and organs and the outside environment. There is no opening in the skin. The problem with blunt trauma is that the injuries are not as obvious to the naked eye. So mechanism of injury is important to know. Depending on the force of the blunt trauma, serious injury can occur to tissues and organs underlying the point of impact. Blunt trauma is caused by different types of forces. A deceleration injury occurs when a moving object comes to a sudden stop, such as a fast-moving car hitting a tree. An acceleration injury is when the head is suddenly struck by a rapidly moving object and the brain is put in motion, such as with a baseball bat or a hockey puck, for instance. Shearing forces can be best described as ripping or tearing of tissues, nerves, or blood vessels. A crush injury can be devastating as it causes massive damage to tissue and underlying structures. Torsion is a twisting injury. I think of spinal cords here as a good example. And compression injuries occur either from the top down or the bottom up. Think of vertebral injuries such as a diving accident where the victim hits their head, or a fall where the victim lands on their feet. Attention needs to be directed towards the spinal cord. Penetrating trauma is a bit more obvious. Victims of penetrating trauma are at much greater risk for developing infections, as the protective skin barrier has been broken. Because the internal organs are very vascular, bleeding and therefore shock can be common. As you may have noticed, this patient has a chest tube in, so for sure the lung was compromised. I might also note that the patient has a compromised chest wall from a sword. There are some other mechanisms of injury we don't often think about. Luckily, there are not too many blast injuries in the United States, but we must consider our members of the armed services who may have suffered a blast injury in a war and the resulting trauma such as traumatic amputations and traumatic brain injuries. Special consideration needs to be given to pregnant women, children, and the older adult involved in a traumatic accident. If you find yourself working in an emergency department sometime in your career, you may be offered the chance to take the Trauma Nurse Core course. It will introduce you to all these topics and help you to appropriately assess and manage trauma patients. Not all facilities can handle life-threatening traumatic injuries, and designations are assigned to hospitals that identify their capabilities. For instance, a Level 1 trauma facility is one identified as a regional trauma center due to its 24-hour availability of in-house specialists and services such as neurosurgeons, whereas a Level 4 trauma facility may only be able to provide basic trauma care. Teamwork is key and begins with EMS giving critical information regarding the mechanism of injury and interventions pre-hospital. Not all injuries are considered life-threatening, but all incidents are assessed in the same manner, beginning with the primary survey, also known as the initial assessment, the A, B, C, D, and E's. The primary survey is where life-threatening injuries are identified quickly and managed in an orderly manner. Realistically, in a trauma code, a multidisciplinary team will complete these steps simultaneously, but for the sake of this lecture, let's break them down sequentially. Before you even lay hands on your patient, you should be able to assess from afar whether your patient is alert or awake and whether there is any active hemorrhaging that needs to be immediately addressed. Without an airway, oxygen will not get to the tissues and your patient will become quickly acidotic, part of the lethal triad. If your patient is not spontaneously breathing, then the airway needs to be opened, but not the way you open airways in a non-trauma patient. You never do the head tilt chin lift. For as part of the airway, cervical spine immobilization goes hand in hand. Opening an airway with a head tilt can result in a transected spinal cord if there are broken cervical vertebrae. With a transected cord in the cervical region, your patient will be unable to initiate their own breaths. Remember this mantra: C3, C4, C5 keeps you alive. You will learn this with spinal trauma. Therefore, opening an airway in a trauma patient requires a jaw thrust only, but only after the cervical vertebrae have been immobilized. No exceptions. Lung sounds are then auscultated to assess for obstructions such as stridor. Prior to bagging a patient who has inadequate ventilations, make sure to look inside the airway for what I will call debris, such as bagging vomit into the lungs, which would probably lead to ARDS. Bagging with big debris such as food, blood, or teeth can re-occlude the airway. Compromises to the airway can occur with the mouth, face, or thoracic trauma. Burn patients with potential laryngeal edema may present with a hoarse voice or pain with swallowing or coughing. Hemoptysis may also be present. Consideration needs to be given then to intubate and secure the airway. Patients who are multi-system trauma patients with suspected cervical vertebral injuries, especially those with a low Glasgow Coma score, must have their C-spines immobilized until cleared by an X-ray or a CT scan. Special considerations need to be given to the older adult populations whose fall would strike their heads. Immobilization occurs with a correctly sized, semi-rigid cervical collar that is securely fastened. The spine board is used pre-hospital for ease of transportation, but is removed upon arrival to the ED. Cervical spine immobilization, though, is still maintained. After airway and C-spine immobilization, breathing is the next step to the trauma assessment. You are assessing for both spontaneous rate, depth, or tidal volume, and effectiveness. Make sure there is symmetrical chest rise and fall, and both sides have adequate breath sounds that assure you the lungs are inflated. Normal respiratory rates are between 10 and 20, or 12 to 20, my apologies. So if your trauma patient has a respiratory rate of 8 and they cannot maintain their tidal volume, they may need assistance from a bag valve mask providing 100% oxygen until intubation can take place. Bag the patient between 10 to 12 breaths per minute. Watch for abdominal distension, as poor airway positioning during ventilation can cause air to move into the stomach and result in vomiting, thereby compromising the airway. Trauma patients with potentially life-threatening injuries are treated with 100% oxygen via a non-rebreather mask if they can maintain ventilations. Respiratory rates greater than 20 can indicate shock in various stages. Monitor the pulse oximeter readings unless the patient has a suspected inhalation injury with carbon monoxide. Tidal volumes can be affected, especially with thoracic trauma, as the patient splints due to pain. Is the chest rising and falling symmetrically? What is the skin color? What color are the nail beds? Is the patient using accessory muscles, indicating that they are in distress? Thoracic trauma can quickly lead to hypoxia and acidosis. Your patient has a patent airway and they are being bagged or can breathe adequately on their own. The next step in the initial assessment is to check for a pulse. At the same time, note the patient's color. What is their skin temperature as you palpate for the pulse? Are they dry or are they wet? Note the quality and rate of the pulse. Does it feel fast or slow, or is it strong and steady, or thready? If a strong radial pulse is palpated, the systolic blood pressure is more than likely greater than 80 millimeters of mercury. If thready, then central pulses need to be checked, either femoral or carotid. Absence of a radial pulse, but the presence of a carotid pulse will likely represent a systolic blood pressure of at least 60 millimeters of mercury. Now, look for obvious signs of bleeding. External bleeding needs to be controlled with pressure, either directly on the site or at a pressure point proximal to the bleeding if pressure is not effective. Bleeding is not always obvious and external. Look for neck vein distension, which may indicate a tamponade or tension pneumothorax. The physician in the ED may perform a FAST exam, which is an ultrasound of the abdomen looking for internal sources of bleeding. If the patient is bleeding and it is uncontrolled, a rapid infusion device is used to quickly transfuse the patient with blood. Once assessed, 2 large bore IVs are initiated, either a 14 or a 16 gauge catheter, followed by isotonic infusion of either normal saline or lactated ringers. The fluid should be warmed. Lactated ringer solution more closely resembles the composition of the electrolytes in plasma. Hypovolemic shock is common in a bleeding trauma patient. Fluids are no longer administered unregulated. The goal is to fluid resuscitate the patient to a systolic blood pressure of 90 millimeters of mercury, so that further bleeding does not occur as higher pressures dislodge clots that have been formed. At one point, blood loss needs to be replaced with blood at a 1-to-1 ratio when infusions of isotonic fluids are ineffective due to a huge loss in oxygen carrier capacity. In the absence of a type and cross, O-negative blood will be transfused until the type specific is identified. Care needs to be given to the calcium level when the patient is massively transfused with blood, as the preservative in blood binds to calcium and causes hypocalcemia. Remember, one vital role of calcium in our blood is part of the clotting cascade. IV calcium gluconate or calcium chloride will be used for low calcium levels. Next comes D for disability, which entails a brief neurological assessment to determine level of consciousness. One tool used to quickly identify the alertness of your patient is the AVPU scale, where A indicates the patient is alert on your approach to bedside. This does not necessarily mean oriented. If the patient is not alert but responds to verbal stimuli by calling out their name or responding with a small shake, they get a V designation on the scale. If they only respond to painful stimulation, they're giving a P designation. If there is no response to painful stimuli, they get or are unresponsive, they get a U. Are they spontaneously moving or following commands? Can they move the upper extremities but not the lower extremities? Do you suspect spinal cord issues lower in the vertebral column? Quickly assess the pupils for baseline size and reactivity. The Glasgow Coma Scale is frequently used as an objective measurement of neurologic status and provides much information when trended. We will talk in more detail about the GCS during the neuro presentation. A score less than 8 means the patient will be unable to maintain their own airway and must be intubated. Also, if the patient is neurologically impaired, the ED staff should consider assessing an ABG, a blood alcohol level, a urine drug screen, and a blood sugar. Finally, we get to the end of the initial assessment with an E, indicating the need to expose the patient or remove all clothing. And E for environmental control, or keep the patient warm. Remember, cold blood doesn't clot, and cold blood shifts the oxyhemoglobin curve to the left, which means that the hemoglobin is not going to be willing to unload oxygen to the cells. Evidence must be preserved, so be careful with the trauma shears when removing clothing. After the initial trauma assessment is completed, the team will move on with the rest of the alphabet. Let's talk about F and G. Believe it or not, it is now time to finally get a full set of vital signs, which includes a blood pressure and temperature. Until the patient is stabilized, vital signs are done frequently. F also stands for family presence. This is a very stressful time for the family, and it is imperative that you keep them informed on what is happening in the trauma bay. Choose a liaison to be the spokesperson for the trauma team, such as the social worker, a chaplain, or a psychiatric nurse. Remain sensitive to the ethnicity, religion, and cultural background of the patient. Evidence shows that if family members want to be present during a resuscitation, they be allowed in the trauma bay. They can witness how much is being done for their loved one, even though it may make you uncomfortable. G stands for get monitoring devices and give comfort. Monitoring devices include lab work, including a lactic acid level, a cardiac monitor, continuous pulse oximeter, and end-tidal CO2 monitor if the patient is intubated. A Foley catheter is often inserted in an NG tube if the patient suffers from severe trauma. It is important to remember that this patient is a person, and if they are awake and in pain, this is an extremely frightening experience. Make eye contact with the patient, let them know you are there for them, and that the team is doing everything they can for them. Provide those simple, comforting words. It takes very little effort. They are more likely to follow directions for you if you give them a little information about what is happening around them, as they are surrounded by many bodies working in what I like to call organized chaos. Let the patient know that soon you will be able to give them pain medications once the assessment is completed. Pain management is an important component to trauma care, using pharmacologic and non-pharmacologic methods. The secondary survey begins with an H, which stands for history. Hopefully the patient's history is already in the hospital system, but if not, then hope for family presence if the patient is unable to provide this information on their own. The quick and dirty mnemonic to remember questions that need to be asked is sample. What symptoms is the patient having that is related to the injury or illness? What allergies does the patient have? any medication use, and this includes prescription medication, herbs, and over-the-counter medications. Also ask about anticoagulant use. P stands for past medical as well as surgical history. Comorbidities place the patient at higher risk for complications following the initial resuscitation. L stands for the last meal ingested if you could ascertain that information. Many trauma patients end up in the operating room as this is extremely important information to relay to the OR team prior to the induction of anesthesia. And E stands for events that led up to the trauma or environmental factors. The other H stands for a thorough head-to-toe physical assessment. You may be wondering how long it takes to finally get to this step, but trust me on this one, it is minutes. All the steps that precede this are done very quickly, methodically, and in a rapid, organized fashion. Bony prominence are palpated, bowel sounds are assessed prior to palpation, all pulses palpated, and all extremities are examined circumferentially. You would be surprised what is hidden in armpits, like an unfound bullet hole. If the patient is not able to respond to questions regarding pain during palpation, look for facial grimacing. In this specific patient, abdominal trauma will be suspected. The final I stands for inspect the back. The patient will be log rolled, and the physician will palpate the vertebral bodies to look for evidence of fractures, any other trauma, and pain. If none suspected or no further trauma is noted, the backboard is typically removed at this time. Prior to rolling the patient back, the physician will insert their lubricated gloved finger into the rectum to check for the integrity of the spinal cord. What they're looking for is a tightening of the rectum when the finger is inserted. If this does not occur, a transected cord will be suspected. Further assessment and diagnostics will then be required. This will be further discussed during the spinal cord trauma lecture. I have discussed labs that will be drawn, such as blood alcohol level, a type and cross, and a urine drug screen. These are just few of the diagnostics that may be done while in the emergency department. A trauma panel typically indicates a CBC with differential and coag studies, as well as liver and pancreatic enzyme levels if abdominal trauma is suspected, and cardiac enzymes with thoracic trauma. Trauma bays have overhead X-ray capabilities, so a chest X-ray and C-spine films can be taken immediately. Tetanus shots are administered for any signs of penetrating trauma. When abdominal trauma is suspected, you may see a FAST exam completed in the ED. That stands for Focused Assessment with Sonography for Trauma, that detects peritoneal bleeding. Presence of peritoneal bleeding will get the patient a ticket to the OR. CT scans may be done out of the department once the patient is stabilized and not going to the OR, or possibly an MRI. Women of childbearing age will have a pregnancy test. This is also the time to apply splints, complete wound care, or have traction applied as needed. MODS, or multiple organ dysfunction syndrome, typically occurs days to weeks following a severe traumatic incident, and is a key contributor to death following trauma during the third peak. It is usually the result of an uncontrolled inflammatory response, say due to sepsis, or continued decreased perfusion to the vital organs. Therefore, the goal of trauma care in the units is to support ventilation, oxygenation, and perfusion, correct the coagulopathies, and keep the patient infection-free. That about does it. This concludes this presentation. Please feel free to ask your instructor for any help should you have remaining questions. Thank you for listening.